I now have the pleasure of introducing a speaker. I know many of you may know, but for those that are new to Kentucky Open, we'd like to introduce Dr. Devin Oller, who's a primary care and addiction medicine physician and served as one of the first Rural Health Leadership Fellows and chief resident at Massachusetts General Hospital before coming to UK. Dr. Oller is an associate program director for UK Internal Medicine Residencies Program and a co-investigator on the Healing Communities study. So now welcome and turn it over to Dr. Oller.
Thanks, Chris. Can you hear me okay?
Yes.
Awesome. Let's rock and roll, guys. I'm going to go ahead and share my screen and take over duties here. So here's our practice gap. What we hope to work on is that there's this issue with language being used intentionally or unintentionally, and it perpetuating stigma and acting as a barrier to getting folks who need care for addiction in, and that by changing our language, we can address a crucial component of reducing stigma and improve the lives of people living with opioid and other substance use disorders. The main sort of a skeleton behind this talk is really identifying language that can be used intentionally or unintentionally to perpetuate stigma, explain the importance of medically appropriate language for substance use disorder, and using effective terminology when discussing people who use drugs. And my goal, what I hope you guys take away, is that you can utilize this client-centered, person-first language, and that's going to improve your ability to engage clients in care. You can also hope to recognize some personal bias or bias of others when treating clients with substance use disorder. So let's kick things off. Language and stigma in the care of people with substance use disorders. We're going to start actually 40 years ago. This was a New York Times article in July of 1981. And it mentions this rare cancer seen in, as they say, 41 homosexuals. 8 of the victims died less than 24 months after the diagnosis was made. And it quotes a doctor, health professional, saying this: the best evidence against contagion is that no cases have been reported to date outside the homosexual community or in women. So this was actually the first report in the general public about HIV/AIDS. And already you're seeing stigmatizing language, specifically around men who have sex with men. And what it's doing here, what stigma is doing in almost all cases, is it's giving people a locus to direct their fear, to direct their anxiety around issues that are often outside of our control or that we don't understand well. And so if you fast forward, 40 years now, when you think about sort of opioid use disorder and substance use in general, you see a lot of this same language, that it's other people's problems, that that it's not sort of in our communities, that it's these people, right, who have this issue, and it's not us. HIV/AIDS, as most of you guys know, is a chronic disease that has very good outcomes with effective treatment. And the same can be said about opioid use disorder. It's a chronic disease with highly effective treatment and great prognosis with that treatment. And the thing that gets in the way of that treatment again and again and again is stigma. The thing that changed with HIV/AIDS almost a decade into the first cases being reported is there was a young man who developed HIV/AIDS from a blood transfusion. He had a rare childhood cancer and developed HIV/AIDS and died from that. And suddenly the sort of population saw that, hey, this is a disease that can affect almost anyone, there's certain behaviors and certain risk factors that increase that risk of developing HIV/AIDS. But anyone could potentially get this. This is in our communities. These are the people that we care about. And that individual's name is Ryan White. And you might have heard of that name because that's the act that now provides for funding and support to anyone living with HIV/AIDS. So where there's uncertainty around a disease process or just something in society that we don't know sort of the origins around, there's fear. And wherever there's fear, there's going to be stigma and stigmatizing language being used so that that fear can be directed outward rather than inward. The way that we combat this fear is by really thinking about the disease of addiction as a chronic disease. And so we're going to go through some of the evidence about why it's a chronic disease, because I think that can be helpful when sharing with friends, family members, or even people living with opioid use disorder, why it's a disease and why it has good outcomes with treatment. So the first thing we ask when asking if something is a chronic disease is whether it is long in duration and associated with persistent and recurring health issues. And substance use disorder absolutely meets those criteria. If you look at sort of the overall trajectory of diseases like type 1 diabetes or hypertension or asthma, those are diseases that actually have significant relapse rates or recurrence of disease rates around sort of 50%, around half of people with these diseases are going to have a relapse over the course of their illness. And drug addiction is the same, around sort of the same numbers. We see a return to use or recurrence of use in about half of individuals living with addiction. The next question that we ask if we're determining if something is a chronic disease is whether it has mixed causes involving some heritable component, so something that's inherited from our family via genetics, and some behavioral component usually. And by our best estimates on research paper after research paper, we see that around 40 to 60% of cases of substance use disorder have a strong genetic component where the mother or father of that patient or the sibling of that patient also has a substance use disorder. And then the last thing we ask to determine whether something is a chronic disease is whether there's no definitive cure. So this is a disease that somebody's going to live with, right? And that we can manage, and whether it requires ongoing care. And for substance use disorder, I think both in many ways are true. So we see that in folks living with high blood pressure or hypertension, before they come into care, their blood pressure is through the roof. With effective care, with blood pressure medication, but also with diet changes, with exercise, with weight loss, we can bring that blood pressure under good control. But when people fall out of care or they have a slip in terms of going back to their prior diet or they have weight gain, we can see that blood pressure begin to creep up again. And we see similar things with addiction treatment, where folks come in with a huge burden of disease, that this is affecting their family life, their work life, their legal status. When they're in treatment, those domains get better, and they stay better as long as folks are keeping up with the things that are important to them and maintain their recovery and remission of their disease. But then when there's a recurrence, you start to see that rebound and some of those same issues, those same sequelae begin to come back. So what I hope to impart here, number one, is that addiction is a chronic disease. It has a really good prognosis and it has effective treatment to manage urges, thoughts, feelings, emotions, cravings related to use. And if people are still reluctant to think about it as a disease process, I encourage you to go through this case with them. So have them imagine a patient admitted to a hospital with heart failure. So they're volume overload, they have a lot of fluid, they're feeling short of breath. You've probably seen heart failure patients before. And what if, in this scenario, the emergency room told them that they would only be given oxygen to help them breathe if they signed a behavioral agreement stating that they would not eat salty foods brought from home? What if they were told by their admitting doctor that it was their fault that they developed heart failure because of their diet or exercise patterns? And what if they were told that they wouldn't receive diuretics, things to pull off some of that water and allow them to breathe better, because that would just encourage them to eat more salty foods? And what if they were denied a defibrillator, something that could actually save their lives if they go into abnormal rhythm because of their heart failure, because of their past behavior when it comes to either adhering to their medications or adhering to a low sodium diet? I think all of us would take a look at a case like this and say, what are these doctors doing? This is malpractice, right? We treat whoever comes into our hospitals and we try to make them better, right? And so why do we think about a patient like this struggling with the disease of addiction different? So they're admitted to the hospital with a heart valve infection related to their injection opioid use. They're told in the emergency room that they cannot receive buprenorphine to manage their withdrawal symptoms unless they sign a behavioral contract. They're told by their admitting doctor that it was their fault for developing the valve infection. They're not offered a valve replacement because of their past behavior, and they're not offered a naloxone kit, something that could save their lives, could reverse an overdose, because that would just encourage them to use again. I think you guys are seeing where I'm headed. The difference between those two cases are not really medical. They're not really related to the chronic diseases that these individuals have. They're related to the stigma that's attached to each of these diseases. So these patients are treated differently because of stigma. The WHO has studied social problems and their associated stigma for decades. And consistently, year after year, when they show a ranking of which problems are associated with the most stigma, addiction is almost always ranked number one. HIV, which I mentioned earlier, is often in that top 4 as well. And you can see here that alcohol addiction is ranked number 4. Stigma is associated with poor mental and physical health among people who use drugs independent of the severity of their illness. So that stigma itself can make their poor mental and physical health worse. It's one of the reasons that people aren't able to access treatment. If you have doctors, if you have other providers who have a lot of stigma towards treating these individuals, they're not going to offer that treatment as often. And then we see patients who have Medicaid, about 9 out of every 1,000 have a diagnosis of opioid use disorder, but only 0.5 of those 1,000 patients receives effective treatment for opioid use disorder. So these days we see that number around 10 to 20% of people living with opioid use disorder are getting effective care. If that was the case for heart failure or diabetes or blood pressure, whole systems, whole institutions would change everything about their practice to get those people into care so that you had less death, you had less morbidity, you had less people really suffering. But we don't because of stigma. This was a really interesting thing. So stigma can come from a lot of different places. This study by McGinty and colleagues published a few years ago looked at over 6,000 newspaper articles really over the last decade, seeing how the opioid epidemic was covered. And about half of those articles use some stigmatizing language. The other half used, or almost half used, fairly neutral language. Only about 2% of articles actually use intentionally sort of patient-centered language, whether it was a person who uses opioid use disorder or a person who uses opioids, a person with opioid use disorder, a person who uses opioids. That sort of person-first language was very, very rare in just the newspaper coverage, the media coverage of the epidemic. So together, you have sort of the existing historical stigma around drug use itself. And then you combine that with us as a society really needing a scapegoat to make sense of, to try to begin to understand the fact that in the last year, 100,000 people died of an overdose. Those things combined are a really bad mix when it comes to getting people the care that they need in a way that is patient-centered. Let me just pause there. Any questions about sort of where we've come from in terms of stigma and those cases that I mentioned? Okay, so we'll keep moving forward. So this is sort of stepping back and just talking a little bit about our theories around sort of stigma and where it comes from and what contributes to it. So stigma is defined as an attribute, behavior, or condition that is socially discrediting, meaning that things become stigmatized by us as a community. The disease itself is not inherently the thing that makes it stigmatizing. It is what we as a society perceive about that disease. And so if we as a society see something that is not perceived as something that the individual has control over, or that there's an external perceived cause, there's pretty low stigma associated with those conditions. So you think about sort of like childhood cancer, right? Where really it's often genetics or a random mutation that's causing that to occur. We don't have a lot of control over it. It's not really that individual's fault, or there's not associated behaviors with that disease process. That's going to be fairly low in terms of the stigma. But when you have as a society a disease where there's high perceived control, or the cause is perceived as coming from that individual themselves, that's where you're going to see more stigma, because you can direct blame at that one individual. People who use drugs, or PWUD, experience a couple different types of stigma as they navigate care. So there's stigma from the recovery community, and we're going to talk a little bit more about what that looks like in the rooms. Stigma from outside, right? So basically the outside of their social circle. Stigma from healthcare workers, and actually sort of stigma directed at themselves, right? And that can be sometimes the most challenging stigma to address is when individuals have heard this language again and again and again and have really internalized it and use it themselves. So I want you to think about sort of for a moment, and you can put it in the chat box, any examples that you might see of these different types of stigma. Go ahead and take like a minute to either think about that, reflect on it, or provide an example in the chat box if you feel comfortable. Thanks, Brooke, for sharing. So stigma from healthcare workers, asking a person in active addiction or in recovery, are you clean today? So like clean or dirty, yep. Within the recovery community, MOUD is not always viewed as recovery, yep. Yep, so, and John sort of internalizing this view as a society of substance use disorder as a moral failing. Yeah, and Nick just re-emphasizing Shannon's point of sort of that language around clean being associated with absence of MOUD despite its really good outcomes. And for those who don't know, medications for opioid use disorder is MOUD. Negative reaction to using naloxone multiple times on the same person, right? Thanks for sharing, guys. I think that captures a lot of what we're seeing. I think you can add to that even more people who use multiple drugs, right? I think while opioids have a ton of stigma, there's also a ton of stigma with methamphetamine use, right? But there might be less stigma associated with alcohol or tobacco or cannabis use. And so that is also a product of what we as a society deem appropriate in terms of the spectrum of behaviors around substance use. So how does stigma impact the individual? So like our case earlier, they may not be offered valve replacements or other critical health interventions when they're presenting an acute need. They might be denied access to housing or interest into a skilled nursing facility as a result of being on medications for opioid use disorder. This is a really hot topic nationally at skilled nursing facilities because it may represent in some cases violation of the American with Disabilities Act, the ADA. And so there's active cases being worked through of skilled nursing facilities denying entrance for people living with opioid use disorder. It can become a huge barrier to jobs and not just sort of getting in the door, but getting promotion as well and getting to that next level. And then custody and other legal issues, a huge impact of stigma. So what do we do about this? So really our first step is trying to change as much as possible the language that we use. We'll talk in a little bit about responding to other people who might be using stigmatizing language, but one strategy in coping with that is just continuing to use appropriate language that's person-centered. So on the left, you'll see some problematic words or phrases, things that I often try to avoid when talking about substance use or people who use substances. So addicts, alcoholics, users. So the problem often with these words is that an individual's disease or behavior does not have to define them, right? So we prefer people first language. So a person who uses drugs, individuals with problem drinking, people get engaged in risky use of substances are preferred over those other words. It might be a mouthful, but it makes a difference to redefine that as a disease that they have and not a disease that defines them. Clean or dirty. So no human being is dirty, right? So we want to try to avoid using clean or dirty, even when talking about urine tests, because a urine test described as dirty actually doesn't give me as the doctor a lot of useful information, right? Instead, saying a urine test that showed blank was present or blank was absent, right? So, somebody who is on buprenorphine or Suboxone for the treatment of their opioid use disorder, you could say that their urine is clean, but actually I want to see buprenorphine in that urine to demonstrate that the patient is appropriately taking the medication. So somebody saying the urine was clean makes me confused and actually a little bit anxious about whether the person is taking their medication appropriately. But saying the urine test showed only buprenorphine is really encouraging and actually more effective way of communicating that information. So relapse, when you ask people who use drugs, sort of their preferred term around this, it's often not relapse, because relapse may not capture truly sort of what that use was, right? It may not be that their disease of addiction was completely met all criteria for a substance use disorder with that one-time use. And so often I will reflect the language used by the patient or use slip or return to use rather than relapse. Substitution, replacement treatment, medication-assisted treatment. So again, I think we can be more straightforward and more effective by simply saying medications for opioid use disorder or medications for alcohol use disorder. Because on the left, the substitution medication-assisted treatment, MAT, sort of falsely implies that one drug is being substituted for another, or that the primary treatment is something other than the medication, when sometimes the medication is effective treatment in and of itself. I'm not saying for all patients that's the case, but sometimes it is. So rather than saying that and it being a little bit nebulous what we're trying to communicate, simplifying it to medications for opioid use disorder, MOUD, is much preferred. And then our last one, similar to our first example, somebody is not defined by their disease, even when that disease is something that happened more in the past. So saying substance use disorder in chronic or sustained remission is much more appropriate than a former or reformed addict or alcoholic. So those are just a few examples, but maybe the most egregious example that I still see all the time in our charts in the hospital and just use colloquially in news reports and other things is abuse, right? And so this word actually is derived from a term meaning a wicked act or practice, a shameful thing, a violation of decency. There's a lot of moral baggage associated with this term. It's associated with behaviors that are not the result of the chronic disease process, like rape or domestic violence or child molestation. And we actually know that when we give clinicians a case, like an example case, and we use terms like substance abuse or abuser, they're more likely to recommend punishment or more strict protocols and how that patient is managed versus person with substance use. So trying to avoid this as much as possible would be good. Any questions about some of those specific terms or terminology? I just want to highlight in the chat, Nick, thank you for sharing that. Nick says I was not offered a valve replacement when I had endocarditis, even though I had a hole in my heart valve. I still worry about that often, right? Those decisions that are really blurred by the stigma that we as a society have towards substance use doesn't just impact that individual in the moment, it can have long-standing issues down the line. But any other questions about the terms? And I'm often asked, is this just, to be politically correct? And the answer is no. This is to save lives. This is to open doors to more people getting treatment. If we can use that language, people are going to be more likely to seek help when they want it and need it. And I can't emphasize that enough. All right. So the second thing that we can do is change the way that patients themselves living with substance use disorder see their disease. A while back, I did a study with some colleagues where we asked a bunch of patients who came into our bridge clinic sort of the way that they saw their addiction. And we got a lot of really interesting responses. And one of the most important ones was this. This patient said, the people with substance use disorder, they're so used to being shunted and not listened to and looked down upon and told it's a matter of willpower. And so they have a lack of belief in the disease model, right? These doctors that are saying, this is a chronic disease, we can manage it, we can get this under control. They're not believing because so many times they've gone to doctors, they've gone to nurses, they've gone to social workers, and they felt like they've been treated differently because of this behavior. So one way around this is to just ask patients sort of what they think caused their addiction, how they think it's been impacting their body and mind, and how it will get better, right? And this comes from the famous medical anthropologist Arthur Kaplan, who basically was seeing cases among a population in California of refugees from Southeast Asia. And they were often having spells that weren't seizures or things like that. And he started asking among that community sort of what they think caused that issue to happen and what they think impacts the body and mind and how it gets better, and actually found some alternative ways to address it outside of sort of what we think of as effective treatment of that condition, and saw improvement within that population. So it's really important to understand where people are coming from, and often we skip over this part of trying to understand when addressing this issue. So when we ask coaches sort of what they think, where they think addiction comes from, they have a couple different answers. So we saw one person said, addiction is physical, mental, and spiritual. I don't mean religious, I mean like a deep, deep gaping hole in your soul. Another said, nobody wants to feel alone. Loneliness is such a part of substance use, that feeling of not being good enough, of feeling alone, of feeling isolated, of feeling different, right? And you can see how understanding this, coming from a patient's perspective, we can better cater our recommendations. We can better address their specific concerns if we know that this is where they think this disease has emerged. This was another study that asked individuals who smoke sort of about the idea of addiction being this chronic brain disease. And this response, I think, is good for a couple of reasons. One, it sort of emphasizes the key point of trying to understand where people are coming from, but also that it's okay for people to be skeptical about the brain disease model. It doesn't mean that you can't help that individual. It just means that you're going to try to help them from a different framework, a different perspective. So they say, I guess it clarifies, talking about the brain disease model, exactly what processes are going on inside your body in terms of why the smoking gets a hold of you. It's just massive overstimulation of receptors, then leads to them being so deadened that nothing affects them anymore. I still think that it is a choice to start. And then once one is aware that they're addicted, it's not really something you can turn around and say, well, it's not my fault. My brain told me to do it, right? So you can see in this person holding both these views of, it makes so much sense that this is what's happening at the brain level, but also still the somewhat stigmatized view of like, it's just a choice. That person ultimately got themselves into this mess, right? And so the way forward is trying to see sort of where there is overlap, where we can begin to get some common ground around the things that might be able to help them. And the way that we do that is often asking about how it impacts their body and mind, right? Because if we know those specific impacts, we can talk about treatment, we can talk about management strategies that are targeted towards those areas, those domains of life that they're struggling. The challenge is often that it's not always clear cut how they see it affecting their body and mind. And often they use metaphors to describe that. And I love this quote from this study back a couple decades now, of metaphor being a solar eclipse, and that it hides the object of study, right? It makes it a little bit more difficult to determine what they might be talking about, but at the same time reveals some of its most salient and interesting characteristics when viewed through the right telescope or through the right lens or perspective, right? When talking about addiction specifically, there's been research looking into, how do people describe their addiction? And often it comes down to 4 common metaphors. So one is sort of this pain. Somebody described it as a big boil filled with poison that they were dealing with, that they could lance it, but it would come right back, right? Others talked about this void, and we heard this from one of our patients in our own study, that there was this hole, and I kept trying to fill this hole. in my life. Detachment is a common one. So when I was sober, I felt like my emotions were boxed in. It allowed me to sort of escape from that, right? And battlefield is really common in a lot of chronic disease processes, where we don't always win, right? And often you would hear phrases like this of, I am completely beaten by this disease. Making the use of metaphors that emphasize humanity and choice has the potential to improve outcomes for people who use drugs. So one common metaphor that I use when talking to patients or clients about their substance use is the idea of being sort of the pilot for your own life, right? That most of the time you are in control, right? You are steering that plane. There's ups and downs, there's some turbulence, but you are under control. When we're dealing with the disease of addiction, it's sort of like the brain, sort of like our pilot is hijacked, right? We are being told sort of where to go by that disease. And treatment for addiction is often about returning people back to that sense of control, that they are pilot again, and that we can give them back that feeling again. The last thing that I often ask patients to understand where they're coming from in understanding their own addiction is asking, how will it get better? And sometimes medications are a big part of that. So you often hear this phrase for people both living with addiction and friends or family members who might have seen this firsthand, that medications for opioid use disorder, buprenorphine or methadone, are trading one drug for another. And I think a lot of this gets back to confusion around what physical dependence is and what an opioid use disorder is. So physical dependence, it's helpful to explain it this way. Physical dependence is actually this older term that refers to the fact that over time, somebody on this medication develops tolerance and they experience withdrawal when the medication is stopped or reduced, right? That's it. It's only describing that physiologic process that happens to the body when somebody is taking a medication over a long period of time. Opioid use disorder can include that physical dependence, so needing more of the medication to get the same effect and having withdrawal when you stop them. But it can't only be that. It actually has to affect other domains of life negatively. So you have to have either medical issues as a result of that use, overdoses, high risk use, so injection use, for it to meet that opioid use disorder criteria. So what I often explain is buprenorphine and methadone may cause dependence, but when used correctly, other domains of the client's life improve on medications for opioid use disorder. That's how we know that this is a brain disease, is that when we alter that brain pathway, when we get people out of withdrawal, out of cravings, out of urges, we see improvement in their functioning. The other thing that we often hear in terms of medications for opioid use disorder is a misunderstanding about diversion and misuse. This often drives a lot of stigma about medications for opioid use disorder, because I think everyone has a story of somebody potentially misusing the medication, or using or buying it off the street. And it's important to emphasize diversion, which is selling, lending, or distributing medication intended for your use only. When we ask patients sort of why they use diverted buprenorphine, the vast majority say that it's to manage withdrawal or maintain abstinence when they were unable to get into a clinic. And guess what? Getting into that clinic, same barrier here: stigma, 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 in addition to some of the cost and waiting list issues related at some of those clinics. Misuse. So buprenorphine itself is rarely used by people who inject drugs as their drug of choice. So in a couple of studies, the prevalence of injection buprenorphine use among people who inject drugs was around 0.7 to 1.6%. Very, very low. And guess what? The primary reason most of those individuals were injecting buprenorphine was to treat withdrawal symptoms, right? Not necessarily to get a head rush or a high from that itself, but to feel well, to feel normal. And I think that's a key point to make when talking about medication diversion and misuse. Medications for opioid use disorder and mutual aid groups. So this is the source of a lot of stigma around medications. And I don't think it has to be that way. These communities can exist together and actually help people do better in care. So 12-step communities sometimes hold stigmatized views around buprenorphine or methadone. In one study, they were basically just interviewing folks at an AA meeting about buprenorphine, and they said, it's a crutch. Your time on buprenorphine doesn't really count as sober time. Your recovery clock is at 0 until you're off of buprenorphine. And so you can see how this sort of nudges folks again and again and again towards considering tapering that medication or stopping medication completely. And we know that this hurts clients, not necessarily the act of tapering or cessation, which can be done effectively in conjunction with that provider that they're working with, but just sort of undermining this idea of this medication is there to treat a chronic disease. And we need to sort of make sure that we are getting all of our things, getting all of our goals achieved before considering sort of tapering or stopping medications for opioid use disorder. So it's really important to discuss your client's strategies if they are going to 12-step communities for coping with some of the stigma, right? Are you going to disclose to others that you're on medication? It may be that not sharing that information allows you to get more out of that group, and that's okay, right? The other interesting thing about mutual aid groups is that in one study, when you asked NA or AA participants about their preferred terms, sort of ways that they self-identified themselves, they found that a huge proportion of people use the term addict when describing themselves, but when you ask them what they would actually prefer to be called and gave them a menu of different sort of terminology, person who uses drugs was actually the most preferred. Heroin abuser, heroin dependent was the least preferred of that. So even in these mutual aid groups where you hear stigmatizing language, when you isolate those individuals and ask, hey, how would you prefer to call yourself? It's not addict. It's often person who uses drugs or person with a opioid use disorder in recovery or in remission. So I'm just picking up a good question here from Dr. Darnell. Thank you. What criteria would a doctor use to determine that medication was no longer necessary? So that's a really good question. And this is something that I struggle with day in and day out. And what I have found is that for most patients, having them guide that decision makes the most sense. So I look at, is their disease of addiction in remission, right? So that means that that their medical issues are being addressed. There's not significant social issues related to their use. They're beginning to form really strong and supportive relationships that are going to help maintain that recovery and remission. If somebody wants to start a taper on the earlier side, I think that's okay, but I have that discussion of potential risks. We know that in the 30 to 90 days after a taper, after cessation of Suboxone, that individual is at elevated risk, about 2 or 3-fold of emergency room care and potential opioid-related event, whether that's an overdose or infection related to IV use. And so we really need to be focusing on what does that look like? What guardrails can we put in place during that time when they're coming off of medication to make sure that they still feel supported? So it is a it's about setting expectations that that taper can take some time. It's about making sure that we're reassessing those expectations as we're going through the taper and normalizing that it's okay to pause or slow down a taper. It's about making sure that those domains of life are continuing to improve and flourish despite us tapering down. Those things are good signals that that person's going to do well. Great question. Okay. So I want to move to a slightly different place here. So this is from a novel a couple years back called Cherry, and it's written from the perspective of someone struggling with opioid use disorder. And he says, when you have been afraid for a long time, you see how fear will come and go, how fear will overtake you, how fear will subside, how fear guts you for a moment, how hope puts you back together till the fear comes back, then the hope, then the fear. I was only ever afraid of one thing in my life, and that was heroin, right? And there's so much to unpack here, but I actually think that the hope part of this is really critical. When we actually study this idea of hope, which we've actually done, right? It might seem weird to study this vague concept of what is hope. There's a couple of takes on it. So one is this idea of your own perceptions of agency and ability to generate pathways towards recovery. And then there's sort of the external of what systems are in place to support me, to provide me with opportunities, or maybe put obstacles in my way to getting better. So the reality is it's some combination of both of those, right? That generates that sense of hope among our individuals struggling with opioid use disorder. We know that access to evidence-based treatment for opioid use disorder increases hope. And from a patient that, as part of the study that we did, asking about just their general understanding of addiction, they said this when asked about what it felt like getting into treatment. I don't know the word for it. They were overwhelmed. Hope, I guess, right? So how do we generate more hope among our community? A big way that we can do that is change the way others, so not just patients, but our coworkers, our fellow community members, the people that we go to church with, the people that we work with, the people that we socialize with. How do we change the way that they see a substance use disorder? Because that's the only way that we're really going to change stigma in a meaningful way. So what I want you to do is we're going to take 5 minutes and just going to be quiet. You're going to reflect and write down answers to these questions. So our first question is, what language do you routinely use when discussing people who use drugs that may be stigmatizing? I will say, I do this all the time where I have a slip, right? And I use language that maybe is not ideal. And so we don't have to share all these answers, but I think taking the moment to reflect on that is really important. And then the other question that I want you to write down an answer for is, what would you do if you witnessed a coworker using stigmatizing language towards people who use drugs? So again, we're going to take 5 minutes, and then we're going to come back together and discuss some of these questions. All right, so hopefully we're wrapping up. We're going to start by discussing question 1. So what language do you routinely use when discussing people who use drugs that may be stigmatizing? And I'll start. I'm not above this. So one thing that I've noticed is that there's a condition where somebody related to alcohol use develops acute inflammation of the liver, and traditionally it's been called alcoholic hepatitis, right? You can see sort of the problem with that, because somebody can develop that without necessarily meeting criteria for alcohol use disorder. But more importantly, it may be that when that person first comes in, there's other things that might be causing that acute liver inflammation that we need to look into. So really should be using terms like alcohol-related liver disease, and then specify specifically sort of what's going on. So that's one example that I noticed that I still use often. What are some other things that people wrote down? And you can use the chat or shout it out. Thanks for sharing that, Amy. Yeah, I think medication-assisted treatment, or MAT, right? I think again, it's something that is associated more with an earlier understanding of what we thought the medication was helpful for, with recent data suggesting that medication alone reduces mortality, and that for some patients, that alone is effective treatment, that associated counseling or other services are not necessary to impact mortality rates. Has been a change in the way that we've been thinking about it. Tom, thank you for sharing that. So I think use the example of my struggle when talking with others using stigmatizing language. Disease is not who you are, right? So I think that is so important to emphasize for folks, because then we already showed this, right? That there's really high rates of recurrence or return to use with substance use disorder in the absence of effective treatment. And so when somebody has internalized this disease is who I am, you can see how a return to use can be completely demoralizing, because they put sort of everything behind trying to stay in recovery. Any other examples here? Well, thanks for sharing that. Number two, I think, is a little bit easier to discuss. So what would you do if you witnessed a coworker using stigmatizing language towards people who use drugs? What are some suggestions that you might have? So Nick says, I definitely think I do well with person first language. I feel a lot of us were programmed to use stigmatizing language like clean or dirty. I do use that language from time to time, but always correct myself. Yeah. I think sometimes just talking out loud of, oh shoot, I didn't mean to say that way. Yeah, those people, yes. Good. So that's one strategy, right? Is when you yourself are having these small slips, right? Being able to share that out loud of, oh shoot, I just used this term, I probably shouldn't use that, right? Just doing that normalizes, hey, we're all learning ways to be better around this. And two, it's going to set that example for others. What are some other things that you can do? You can ask a coworker some clarifying questions to not put them on the defensive by accusing them of being intentional about the language. Jeremy, mwah, that's amazing. I love it. So I think it's so much better to sort of call someone in than calling them out, right? So in that moment, it may not be the best time, in front of others to say, hey, we should never use that term, right? But to talk them through, hey, use that, this urine was dirty. I'm wondering if you could clarify a little bit more what you mean, because when I hear dirty, I don't really know what that means, right? Other than something was in the urine that maybe wasn't supposed to be there, but it doesn't tell me sort of what was there, right? So urine was positive for this or negative for that. Andy makes a good point. That frequently found that it presents a bit of a language barrier. Having to translate can be a problem. Developing rapport, for instance, as such, I switch the older, more familiar terms and try to introduce non-stigmatizing language slowly, right? So yeah, so it may be that as you're starting to work with somebody, that rapport is so much more important than correcting or editing everything that they're saying. But you might, in sort of reflecting back to them with simple reflections to show that you're listening, let's say that they say, my sister is an alcoholic and has been struggling with that for a while. I don't think she'll ever get clean. You could reflect back, it must be pretty hard to have a sister living with alcohol use disorder, right? So you're hearing them, what they're saying, and you're not necessarily correcting those terms in the moment, but you're reflecting back to them sort of preferred language that might signal to them, hey, that's actually how I should be talking about this issue. Yeah, especially there's an analogy that's used of, a fish is not going to have a great word for like water, right? Because it's just the thing that it's swimming through. And so somebody coming from a culture or community where this is just the water that they're swimming through, it's going to feel very abrupt to start hearing these other things. And so beginning to sort of meet them where they're at and trying to move them slowly towards that more effective non-stigmatizing language can be helpful. Any other tips that folks have? Things that have worked for them? I can't overstate the importance of using non-stigmatizing language in our documentation, right? So whether we are a nurse or a social worker or a peer support or a physician, people read our notes. They read our documentation of what we're saying about the people that we're working with. And so if they're reading again and again and again, substance abuse, they're not going to sort of say, oh, that must be wrong. This is a person that I trust and that is important to me. Maybe they just don't know that it's something new, right? And so being able to use in your own documentation a good non-stigmatizing person-first language, again, is a good way of modeling a way forward. Yeah, exactly. Assume good intent. Like people are working with population of people who use drugs for a reason, right? Tap into that motivation, tap into that reason that they're there when explaining why it's so critically important that we don't add more layers of stigma as a barrier for folks getting into care. Okay. So I put some references here. Before I jump to questions, let me just summarize. We started in a place where almost 40 years ago, we had a highly stigmatizing disease. And we can see it's still very stigmatized, HIV/AIDS. But the way that things got better, slowly but surely, is that communities who were struggling with that disease shared those struggles. They shared their preferences for how they were called and how to characterize their disease process. They got better because we had effective treatments at controlling that chronic disease. It got better because the faces of that disease process didn't look like what we expected always, right? And opioid use disorder or substance use in general can follow that same roadmap to getting better. One, we can recognize it as a chronic disease, and we can share that idea of a chronic disease that gets better with treatment and has a good prognosis with others. Two, we can ask our patients, our clients that we're working with, how they understand the disease process, sort of recognizing that they might have different views than us of what addiction represents and how it might get better for them. And we can better meet them where they are if we understand that. And then lastly, we can call in, not call out, our colleagues who might be using more stigmatizing language and really use the language of effectiveness. So is that term or is that terminology expressing something important clinically? If not, it's probably not useful. And then the language of person-centeredness, right? We all want to help this community, right? We all want them to have better outcomes. And so let's put the person first in the language that we're using to describe their disease process and how it gets better. So with that, I will turn things over to questions.